Welcome. We're doing a deep dive today, specifically for you, the plastic surgery resident prepping for board exams. Our focus, mandibular fractures.
That's right, a really high-yield topic. We'll cover etiology, classification, evaluation, and management based on the key literature.
Good. So let's start with etiology. What are the most common causes we see?
Well, the big two are definitely assault and motor vehicle collisions. You also see them from um, gunshot wounds, falls, sometimes sports injuries.
Okay. And knowing the cause can sometimes hint at the location, but really understanding the precise fracture location is absolutely critical for treatment planning, isn't it?
Exactly. It dictates the approach entirely.
So let's run through the classifications by location. First, dental veolar.
Right. That's limited just to the tooth-bearing area. The underlying bone isn't fractured through.
Then the condyle. That has subtypes, right?
Uh-huh. Intracapsular, extracapsular, and condylar neck fractures.
Got it. Coronoid process fractures involve, well, the coronoid. Pretty straightforward.
Yes. And ramus fractures are in that region from the gonial angle up towards the sigmoid notch.
Okay. Then angle fractures, right at the gonial angle, often extending near the third molar.
A very common sight. Then body fractures, these run from the alveolar process down through the inferior border, located between the mental foramen and the back of the second molar.
And parasymphysis.
Similar vertical extent, but situated between the mental foramen and the distal aspect of the lateral incisor.
Finally, the symphysis itself.
Yeah.
A vertical or near vertical fracture right in the incisor region.
Precisely. And in terms of how often we see these, angle fractures are the most frequent,
Right. Followed by.
followed by symphysis, then body, then condyle, then coronoid, and finally ramus fractures are the least common.
And you mentioned associations earlier. Assault often leads to angle fractures.
That's the classic association, yes. And MECs often result in body fractures, though, patterns can vary.
And it's important to remember something like 50% of these cases involve fractures at multiple sites.
Absolutely. You always have to look for secondary fractures.
Which brings us to patient evaluation. For any significant facial trauma, a complete head and neck trauma evaluation is just mandatory.
Non-negotiable. And the physical exam needs to be meticulous. Check occlusion first. Look for any anterior or posterior open bite when they're in centric occlusion.
And watch for deviation when they open their mouth.
Exactly. Then, by manual examination, you need to feel for abnormal mobility across the mandible and pinpoint tenderness.
Don't forget condyle palpation,
Hmm.
preauricular, and intraoral, feeling for tenderness and assessing translation during excursion.
Crucial. Also, inspect the lingual and buccal surfaces for any signs of trauma, lacerations, hematomas.
And the teeth. Account for every single tooth. Check their mobility.
Yes, and document any mental nerve paresthesias immediately. That points towards nerve involvement.
Some useful clinical tips here. Always use tongue blades to get a full view inside the mouth.
Good point. And ecchymosis, or bruising, in the floor of the mouth that's considered pathognomonic for a mandibular fracture.
Right. And if the chin deviates on opening,
Strongly suggest a condyle fracture on the side it deviates towards.
and the mental nerve paresthesia we mentioned suggests a fracture line crossing the inferior alveolar nerve canal.
Correct. Now, moving to imaging. What's the standard?
You really need at least 2 radiographic views of each mandibular region. You're looking for the fracture itself, obviously, but also fractured teeth, any teeth in the fracture line.
Degree of displacement, fracture direction, linear or oblique, and the relationship of the inferior alveolar nerve to the teeth and the inferior border.
The panoramic radiograph, the Panorex, is a good screening tool. Gives a nice overview of the corpus, teeth, nerve.
But it's just a screening tool. It's definitely not sufficient on its own for definitive diagnosis or planning.
Agreed. A formal mandible series includes several views: PA skull, right and left lateral obliques, a town projection, and segmento vertex views.
That's the traditional series, though honestly, in the acute setting, CT images are generally superior to plain films.
Much better detail, especially for complex fractures or displacement. And sometimes plain films just aren't feasible, perhaps due to cervical collars.
Right. CT often becomes necessary then.
Okay, let's talk general management principles. First things first. ATLS protocols always take priority. Airway, breathing, circulation.
Always. Life threats first. The good news is definitive treatment of the mandibular fracture itself can often be delayed up to about 2 weeks if the patient is critically injured, provided you start appropriate antibiotic prophylaxis.
And speaking of antibiotics, they're recommended for basically all patients with mandibular fractures, right? From presentation until reduction.
Yes, prophylactic penicillin-based antibiotics, or clindamycin for penicillin allergic patients. This has been shown to reduce postoperative infection rates significantly.
But interestingly, continuing antibiotics after the surgery hasn't shown the same benefit for reducing infection.
Correct. The prophylactic window seems key. And another adjunct, oral chlorhexidine rinses can help reduce bacterial counts, particularly in open fractures communicating with the mouth.
That makes sense. What about the specific issue of teeth in the line of fracture? These are considered open fractures, correct?
Yes, because the fracture communicates with the oral cavity via the gingival sulcus and the periodontal ligament attachment.
But we don't automatically pull every tooth in the fracture line anymore.
No, not at all. With modern internal fixation techniques and appropriate antibiotics, we can usually preserve those teeth.
So when do you need to extract a tooth in the fracture line? What are the indications?
Okay, there are about 5 main indications. 1, grossly mobile teeth, especially if there's periapical pathology or advanced periodontal disease already present.
Okay.
Partially erupted third molars if they have associated pathology like cysts or pericoronitis.
3.
Teeth that physically prevent you from getting an anatomic reduction of the fracture.
Makes sense. 4
Fractured roots, can't really salvage those.
and 5.
If the root apices are directly exposed in the fracture line. But there's a caveat. Even a non-restorable tooth might be temporarily retained if removing it would seriously compromise your ability to reduce the fracture properly.
Interesting point. And what about completely bony impacted teeth?
Those are typically left alone unless their removal is absolutely necessary to achieve fracture reduction. Taking them out can sometimes destabilize things.
Okay, let's shift to fixation methods. The biomechanics here are important. The mandible deals with tension and compression stresses from mastication muscles.
Exactly. And any fixation strategy needs to effectively neutralize those stresses to allow for stable healing.
The two main systems or philosophies we use are the AOASIF system and the Champy system.
Right. The AOASIF approach traditionally uses larger, more rigid plates. Their principles focus on 4 things: anatomic reduction, functionally stable fixation, an atraumatic surgical technique, and enabling early, active, pain-free mobility.
And how do they achieve fixation?
A couple of ways. One is using a tension band and a stabilization plate. So a smaller plate near the alveolar border handles the tensile forces, and a larger, stronger plate along the inferior border manages compression and torsional forces.
All right.
Or using a single, robust reconstruction plate, usually at the inferior border. This is for situations with segmental bone loss or significant comminution. It's designed to neutralize all the stresses, tension, compression, and torsion. It's load-bearing.
Okay. Contrasting that with the Champy system.
The Champy system uses smaller, generally non-locking mini plates. They're considered non-rigid or semi-rigid. The idea here is to place them specifically along lines of ideal osteosynthesis to neutralize the tensile forces primarily, while allowing the bone fragments themselves to handle the compressive forces through stable abutment.
So it relies on bone-to-bone contact.
Precisely. A common application might be a single 2.0 locking mini plate along Champy's line with 4 8mm locking monocortical screws, sometimes combined with about a week of MMF. This can be very reliable for selected fractures.
And Champy's principles are based on biomechanical studies defining those ideal lines.
Yes. The principle is that harmful tensile stresses develop along specific lines during function. So, posterior to the first premolar, a single plate placed in the mid-body region along that line is often sufficient.
But anteriorly.
Anterior to the first premolar, where torsional forces are greater, you typically need 2 plates placed maybe 4 to 5 millimeters apart, again along the optimal lines.
A key point for Champy, though. It absolutely requires good bone-to-bone abutment. It's not suitable for comminuted fractures or areas with segmental bone loss.
Correct. It's a load-sharing concept, not load-bearing like a reconstruction plate.
This brings up different definitions of stability. Can you clarify those? What's rigid stability?
Rigid or absolute stability implies zero movement across the fracture gap under functional load. It's kind of the ideal AO principle, but it's probably not fully achievable in the dynamic environment of the mandible.
Okay. Then functional stability.
Functional stability means there might be some microscopic movement, but it's controlled and balanced by external forces, allowing fracture union to occur without complication. This is what most modern fixation aims for.
And load sharing versus load bearing.
Load-sharing stability is a type of functional stability where both the fixation hardware and the well-reduced anatomically abutted bone fragments share the functional load. This is typical for mini-plate fixation, like champies,
Whereas load-bearing stability.
is functional stability achieved solely by the fixation system itself. The hardware bears the entire load, usually because there's comminution or bone loss preventing bony abutment. This requires a strong reconstruction plate.
Why is achieving stability, whichever type, so important?
Because primary bone healing, the ideal healing without a large callus, requires a mechanically stable environment. Any significant mobility across the fracture gap leads to bone resorption at the edges and ingrowth of fibrous tissue instead of bone.
And if you have internal fixation devices present with mobility,
That's a recipe for problems. It promotes further resorption around the hardware, loosening, and significantly increases the risk of infection. Stability is paramount.
okay, let's walk through the general operative sequence for treating these fractures.
Right. Typically, you'd start by extracting any teeth that meet the criteria we discussed earlier. Then, you establish maxillomandibular fixation, or MMF, capability, usually by placing arch bars, or perhaps MMF screws, or one of the newer hybrid systems like SmartLock.
After MMF setup,
Then you surgically expose, anatomically reduce all the fracture sites. Only after confirming reduction do you apply MMF to hold the occlusion. Then you apply your chosen internal fixation hardware.
you mentioned MMF screws. What are the specifics there?
They're usually 2 mm diameter, maybe 8 mm long, placed carefully at the junction of the attached and unattached gingiva, typically between the canine and first premolar, making absolutely sure to avoid the tooth roots.
And alternatives to arch bars exist too.
Yes, things like 22-gauge embrasure wires looped around teeth, or the SmartLock system, which combines screw and wire elements, can be quicker in some cases.
A critical step after applying the hardware.
You must release the MMF and reassess the occlusion. Check it carefully. If the reduction is perfect and the occlusion is solid, you might leave the MMF off, or just use light elastics. If the occlusion shifted during plating, you need to reapply MMF after confirming the reduction is still accurate, or potentially revise the fixation.
So precise restoration of the patient's pre-existing occlusion is absolutely crucial with internal fixation.
It's non-negotiable. Any discrepancy you accept intraoperatively will not resolve on its own postoperatively. You have to get it right in the OR.
And post-op physical therapy.
Very often necessary, yes, especially for condylar process fractures. Patients need closely monitored PT to rehabilitate the masticatory apparatus and regain full range of motion.
Let's talk specifically about condyle fractures then. You mentioned PT is key.
Absolutely. Early active range of motion is fundamental for TMJ rehabilitation, whether you treat them closed or open. That early rehab is probably the single most effective therapy.
Why is closed reduction often used for condyles?
While surgical access can be challenging, there's risk to the facial nerve, and sometimes the fractured segments are quite small and difficult to fix securely.
So how do you manage a condyle fracture without malocclusion?
Often, just a soft diet and close observation is enough. However, if malocclusion develops later classically, deviation towards the affected side on opening, or a contralateral posterior open bite, then you typically use arch bars and guiding elastics.
And if there is malocclusion present initially?
You can still opt for close reduction using arch bars and elastics. Often just a single class 2 elastic on the affected side is enough to guide the occlusion.
So MMF isn't always required even with malocclusion?
No, and in fact, prolonged MMF can actually hinder the necessary early rehabilitation for condyles. Guiding elastics are often preferred.
When would you choose open reduction internal fixation ORIF for a condyle?
There are specific indications, things like significant displacement of the condylar segment that physically blocks mandibular translation, or if the condyle is displaced into the middle cranial fossa, which is rare but serious.
Other indications.
Bilateral condyle fractures, especially when combined with midface fractures, often need ORF to reestablish the posterior facial height and occlusion. And of course, if you simply cannot establish a normal, reproducible occlusion through closed methods.
Okay. Shifting to angle fractures, you mentioned they are the most common.
And they also have the highest complication rate of any single mandibular region. Infection, non-union, malunion are all more frequent here.
Does ORFF help reduce complications compared to non-rigid techniques that require MFF?
Interestingly, studies suggest the complication rates for ORF are roughly equal to those for non-rigid techniques, assuming the non-rigid techniques are done properly with adequate MMF.
Access for ankle fractures.
Usually, intraoral approaches are sufficient. Sometimes you might need transbuccal trocar assistance for screw placement, especially for plates near the inferior border.
What about body fractures?
Those can be treated either with mini-plate techniques, like the Champy principles, or with heavier reconstruction plates.
Mini plates being load sharing.
Right. They're generally easier to adapt in place, but they're only suitable for non-comminuted fractures where you can achieve good bony contact for load sharing.
And reconstruction plates.
They're load-bearing, harder to contour perfectly, but necessary for comminuted fractures or if there's any bone loss. They provide stability on their own.
Important considerations for body fracture fixation.
Definitely need to be mindful of the root apices of the teeth and the location of the inferior alveolar nerve when placing plates and screws. Access is typically intraoral.
And symphysis fractures.
Similar options, mini-plates or reconstruction plates. Lag screws are also frequently used in the symphysis, either alone or in combination with plates.
What's the key biomechanical consideration here?
Torsional forces are significant in the symphysis. Because of this, you generally need 2 points of fixation, like 2 mini plates or lag screws combined with a plate to resist that twisting. The exception is if you use a single, strong reconstruction plate, which can neutralize all forces.
Access.
Intraoral is preferred here as well.
Let's cover a few special considerations. What about patients with multiple fractures?
When you have multiple fractures, particularly bilateral ones, there's a tendency for the mandible to sort of flare outwards. This means you often need more rigid fixation than you might use for a single fracture, maybe even reconstruction plates, to prevent that widening and maintain the proper mandibular width and form.
Edentulous fractures, those present unique challenges, right?
Absolutely. Reduction accuracy is compromised because you don't have teeth to guide the occlusion. Healing can also be poorer due to often smaller bone stock, reduced blood supply, and sometimes poorer bone quality in older edentulous patients.
How are they typically managed?
The Chalmers J. Lyons Academy study highlighted the effectiveness of using transfacial, often external approaches, combined with rigid fixation using reconstruction plates for these difficult fractures.
So mini-plates or closed reduction using the patient's dentures as splints aren't recommended.
Generally not considered ideal or reliable for definitive fixation in most edentulous cases, especially with significant atrophy. Reconstruction plates offer more predictable stability.
Might bone grafting be needed?
Yes, particularly in severely atrophic mandibles, acute bone grafting might be necessary at the time of fixation to augment the bone stock and improve healing potential.
And finally, pediatric patients. What are the key differences?
Several things. Arch bar stability can be poor because primary teeth, or mixed dentition, often lack the favorable height of contour needed for secure wire placement. This affects the quality of MMF if you're relying on arch bars.
What about internal fixation around developing teeth?
You have to be extremely cautious. Developing tooth buds fill much of the mandible. So if internal fixation is used, it typically involves carefully placed monocortical screws and mini-plates trying to stay above the developing dentition and inferior alveolar nerve.
Condyle fractures in kids.
These need very close long-term follow-up due to the risk of TMJ ankylosis and potential disturbances in mandibular growth. Early rehabilitation is crucial, maybe even more so than in adults.
And MMF duration.
Generally shorter in children, maybe 2 to 3 weeks compared to 4 to 6 weeks in adults because they heal faster. In fact, prolonged MMF in kids can actually impair rehabilitation and potentially affect growth.
Okay, let's quickly recap the absolute key takeaways for board preparation.
Right. First, remember you need at least 2 radiographic views per mandibular region for adequate evaluation, a mandible series, or a Panorex plus selected other views like a CT.
Second, the proper operative treatment sequence. Expose first, then reduce, then place MMF, then apply fixation.
Third, always release MMF and recheck the occlusion after applying hardware. Reapply MMF if needed only after confirming the reduction is still accurate.
Fourth, precise restoration of the pre-existing occlusion is paramount with internal fixation. Don't accept intraoperative discrepancies. They won't fix themselves.
And finally, most patients, but especially those with condylar fractures, will require closely monitored physical therapy for optimal functional recovery.
Excellent summary. This covers the core knowledge on mandibular fractures needed for the boards.
Absolutely. Remember that achieving the best outcomes really hinges on that interplay between accurate diagnosis, meticulous surgical technique based on sound biomechanical principles, and dedicated early rehabilitation. Keep studying these areas in depth.